that time of year again. The 2026 ADA standards of care have dropped. And let me tell you, there are some really significant, practice-changing revisions inside. So in this explainer, we're going to break down the most critical updates that are going to impact how you manage your patients. Let's dive right in. We've got 5 key areas to cover. We'll kick things off with diagnosis and prevention, then jump into the huge shifts happening in technology. After that, we'll talk pharmacotherapy, tackle comorbidity management, and wrap up with some really important updates on care for special populations. So first up, diagnosis and prevention. This year, there's a really heavy focus on risk mitigation, especially around an issue I know we're all seeing more and more of in our complex patients: drug-induced hyperglycemia. So the big question is, what are the new guidelines for actually managing this? Well, the 2026 update gives us some much-needed, very specific recommendations, and this is especially true for our patients who are undergoing cancer treatment. The new guidelines really lay out a clear framework for us. For patients on checkpoint inhibitors, we're now talking about monitoring plasma glucose at every single visit. And for those on PI3K alpha inhibitors, which, as we know, can cause some pretty nasty hyperglycemia early on, that close monitoring in the first few weeks is absolutely crucial. This is a huge step toward being more proactive. But, just monitoring is only half the battle, right? The 2026 guidelines also push us toward proactive prevention. And to do that, they're pointing us toward an old friend, metformin. This is a real game changer. We now have explicit guidance to actually consider using metformin to prevent hyperglycemia in high-risk folks on PI3K alpha inhibitors or high-dose glucocorticoids. This is a major shift toward getting ahead of the problem instead of just reacting to it. Okay, let's get into what is, arguably one of the biggest stories of the 2026 update: technology and glycemic targets. The changes here really represent a fundamental shift in how we should be thinking about things like continuous glucose monitoring and automated insulin delivery. Wow, this slide really says it all. The old way of thinking was, CGM is for certain patients, usually the ones on intensive insulin. Not anymore. Recommendation 7.15 is a total game changer. It's now recommending CGM at diabetes onset and for a way broader group, including adults on non-insulin therapies that can cause hypoglycemia. The door has basically been thrown wide open for using CGM early and often. And it's not just about CGM. Just look at the language here in recommendation 7.25a. Automated insulin delivery systems are now the preferred insulin delivery system. Not an option, not a consideration, but preferred for a huge chunk of our patients with type 1 and type 2 diabetes. The takeaway here is massive. AID is no longer just an alternative. It is being positioned as the new standard of care. And to help us actually implement all of this in the clinic, the guidelines have given us a fantastic new tool: Figure 9.2. This is a brand new insulin algorithm specifically for type 1 diabetes, and honestly, it's a must-have resource for your practice. I definitely recommend taking a closer look at it in the full document. All right, let's move on to pharmacotherapy and weight management. The big story here continues to be the ever-expanding universe of incretin-based therapies. Plus, we've got some new guidance for some really specific and often challenging clinical scenarios. This table gives us a great little overview. We now have recommendations to use dual GIP/GLP-1 receptor agonists in symptomatic HFpEF. For MASLD and MASH, both GLP-1 RAs and the dual agonists are now on the table. And in a really significant move, GLP-1 RA-based therapy is now officially a treatment option for obesity in people with type 1 diabetes. The guidelines also break new ground in an area that, let's be honest, has been a real clinical headache for a long time: glycemic management in our post-transplant patients. And what's great is they've given us a very clear stepwise approach. So step 1, right after the operation, insulin is preferred. Makes sense. Step 2, for the long haul, we can transition to non-insulin therapies, tailoring them to whichever organ was transplanted. Step 3, we should definitely be considering a GLP-1 RA for those extra cardiometabolic benefits. And finally, step 4, if goals still aren't met, we intensify with insulin. It's just a really logical, much-needed framework. Okay, let's talk comorbidity management. For 2026, the 2 biggest updates are a real push for more aggressive blood pressure goals in some patients and some pretty important refinements to our CKD protocols. Let's start with blood pressure.
The new number we all need to remember for our high-risk patients, those with high cardiovascular or kidney risk, is less than 120 millimeters of mercury systolic. Recommendation 10.4 is encouraging this more aggressive target, and that marks a really clear shift in how we manage hypertension in this group.
So that's blood pressure, but what about the kidneys? How exactly have the CKD pharmacotherapy protocols been tweaked for 2026? There are really three key updates to flag here. First, we can now think about starting an SGLT2 inhibitor and a nonsteroidal MRA at the same time. Second, the guidance to use SGLT2 inhibitors in non-dialysis patients to slow down CKD progression is now even stronger. And third, there's new guidance on using GLP-1 RA therapy in our dialysis patients to cut down their cardiovascular risk. It's really all about maximizing that organ protection. Of course, with these more intensive therapies, patient safety is everything. So, recommendation 11.6b now gets more specific on how often we should be monitoring eGFR and potassium when we're using RAS inhibitors or MRAs. This is a super important practical detail for our day-to-day practice. All right, we're on the home stretch. Let's look at our fifth and final section, care for special populations. The 2026 guidelines bring some really important revisions for how we tailor care to both older adults and our pediatric patients. For older adults, the theme is loud and clear. The focus is really shifting towards functional assessment, cutting down on treatment burden, and just simplifying care whenever we can to improve quality of life. So here are the highlights. That broader CGM recommendation we talked about, it extends to this population too, to help reduce hypoglycemia. There's a more specific BP goal of less than 130/80 as long as it's safe. But honestly, the most practical additions are two new resources. Table 13.1, which has validated screening questions for geriatric syndromes, and Figure 13.2, which gives a fantastic, stepwise approach to de-intensifying treatment. These are tools we can literally use in clinic tomorrow. And for our pediatric colleagues, the big news is a reorganization of Section 14 to better separate type 1 and type 2 diabetes. The real centerpiece of this is a new resource, Table 14.1, which is designed to make comparing the recommendations for both conditions much, much easier. So there you have it, a whirlwind tour of the most critical updates in the ADA 2026 Standards of Care. From CGM at onset, to new guidance on post-transplant care, to more aggressive blood pressure targets, there is a lot to take in and integrate. So it really leaves us with a key question to think about. Considering everything we just covered, which one of these new recommendations is going to most significantly alter your approach to patient care? Thanks for joining this explainer.